My name is LOUISE LETLEY. I'm a nurse with the National Immunisation Programme in the UK and work for Public Health England. Thank you very much to the organisers for inviting me today. It would have been really nice to meet everyone face to face in Washington, but it's a great pleasure to be able to talk to you today about our tailoring immunisation project carried out with the Charedi Community in North London during 2015 and 16. As Kath has already explained tip theory and the processes, I will be focusing on the practical aspects of the work. It is worth saying that the UK was one of the first tip projects, and so the guidance has been updated, improved and further streamlined since those very early days. Next slide, please. North London Borough of Hackney is home to the largest Charedi community in Europe. This community of strictly observant Jews was already established in London in the 1920s, but the population grew significantly during the Second World War as new arrivals fled the Holocaust. One of the issues with the project is membership of the community was not systematically recorded in medical records. So it's very hard to estimate the number of the population, but at the time of the survey it was estimated to be between 25 and 30,000 people. The community had suffered recurrent outbreaks of vaccine preventable disease, which indicated suboptimal immunisation uptake. Measles outbreaks occurred in the borough of Hackney in 2007 and 2013, and the Charedi community suffered a higher burden of disease during those outbreaks than other parts of the community. Due to close links with Charedi communities in other parts of the world, measles was exported from the UK to other countries, including Israel and Belgium at that time. There was also perception among health professionals that religious or cultural objection contributed to lower immunisation uptake. Next slide. So this slide gives an overview of the steps taken to deliver TIP, and we were very keen to have community engagement and involvement at every step of the processes. So the initial stakeholder meeting was the meeting that was held with local commissioners and providers of immunisation service, public health professionals, representatives from the National Immunisation Team and experts from the WHO. And at that meeting, discussion was held, and there was a decision to carry out the TIP project within the Charedi community to try and identify some of the barriers and enablers. Mapping of current services involved looking at what was already happening within the community. There had been some small projects to deliver services in a flexible way, but they tended to be short-term and hadn't been evaluated effectively. We also looked at current available surveillance and outbreak data. We then held a second stakeholder meeting, and this is where we had the involvement for the Charedi community, and that included a chief rabbi for health, a Charedi nurse, staff from children's centres, and also representatives from a Charedi support organisation. We also had commissioners and providers of immunisation services. And a lot of the discussion at this meeting focused on a SWOT analysis. So we were looking at the strengths, weaknesses, opportunities and threats of the current immunisation policy. This was a very useful process, and from that we were able to develop a questionnaire survey to go to parents based on the results of that analysis, and that was distributed to parents through general practices and children's centres. Community members contributed to the design, translation into Hebrew and Yiddish, and checking also for cultural awareness. We then carried out an interview study with parents and key informants to get more information around some of the results from the survey, to look at some of the things in more depth. And then we had, when we got all the results back, a third stakeholder meeting, and it was the same stakeholders as had attended the second meeting, so representations from the community, etc. And there was presentation of the results, prioritization of findings, so that we could feed those into the recommendations that we then made for commissioners, providers of the service, and also the community. Next slide, please. There's a lot of work to cover in sort of a 10-minute presentation, so I'm just going to highlight some of the key things that we find. And the data analysis find that Charedi community have larger than average families. 4 to 6 children per family was not uncommon. And general practices serving Charedi community had between 10 and 17% of the registered population being less than 4 years of age. And that was compared to an average of about 6% across England. So they had very much weighted towards the younger age group, but they didn't have any additional resources to cope with that. So that obviously contributed to increased pressure on service delivery. And also parents with large families, it was a real effort to have to go and get immunisations, and it wasn't high priority on their list of things to do with their busy family lives. Next slide, please. The survey of Charedi parents, and we only had mums responding to this survey. Look, it could have been answered by both, but in the community, the mums take most of the decisions around sort of healthcare, etc. The survey, surprisingly, didn't really highlight any issues with religious or cultural difficulties, and in fact, it was more around access, reducing waiting times, child-friendly facilities, things like room for breastfeeding, room to park buggies, not having to wait long times in general practices were mentioned. Next slide, please. And this was the parent and key informant interviews, what might improve vaccination uptake or services. So these were some of the things that came out of the surveys looked at in more detail, and you can have a quick look at those. But again, very similar information coming out from key informants and also from parents. Next slide, please. The key messages was that there was no evidence of any cultural or religious objection to immunisation. In fact, community members' views on immunisation were broadly similar to the wider population. Resolving service access issues should be prioritised to improve uptake. Recording of community membership was highlighted. Collaborating with community members and religious leaders invaluable. And obviously, community-specific interventions should be evaluated for effectiveness and cost effectiveness. Next slide. These were some of the measures. We provided a whole list of recommendations for commissioners, providers, and the community. I haven't got time to go into all of those, but these are some of the measures that were implemented following the TIP work. Practices agreed to do more proactive reminders. Children were flagged on the computer system so that every opportunity was used to remind parents of immunisation. Relevant practices, so these are the general practices to provide immunisation services, had a representative on the Hackney immunisation group, so they got a chance to meet with the public health professionals and the commissioners, etc. And also the practice payment process was altered to recognise the special circumstances, so the practice were actually given more resource. And at the time of this piece of work, the local authority and immunisation providers were exploring options for using community venues, so children's centres and places that might be more accessible rather than the parents having to travel to general practice. Next slide, please. The senior rabbi for health, Rabbi Pinter, was very vocal in his advocacy for immunisation. He was pro-immunisation at the start, and he became more so and was very vocal in his views. This was a piece in the Jewish Chronicle, and you can see the box at the top right-hand corner with his comments. And he became a very vocal advocate for immunisation. Unfortunately, a few months ago, very sadly, Rabbi Pinter died from COVID-19. So we've lost a real valued colleague in the community very recently. Next slide, please. And this is just the team that were involved from a wide area of expertise. And the links at the bottom are to the full report on gov.uk website, and also the paper that was published in Vaccine. Thank you very much.